Rakesh sir, should I share the introduction?
हाँ सर, मैं स्लाइड शेयर कर दूं क्या? फर्स्ट वाला
Hello.
स्लाइड शेयर कर दूं क्या?
Rakesh sir, should I share the introduction?
हाँ ठीक है सर, मैं स्लाइड शेयर कर दूं क्या? फर्स्ट वाला
हाँ, okay. Hello.
स्लाइड शेयर कर दूं क्या?
Rakesh sir, should I share the एक मिनट, ये मेरे में दोनों आवाज आ रहा है, एक सेकंड. इंट्रोडक्शन.
हाँ ठीक है सर, मैं स्लाइड शेयर कर दूं क्या? फर्स्ट वाला
हाँ, ओके.
हाँ.
ठीक है सर.
Okay, I need to share the introduction initially.
अच्छा ठीक है, मैं स्टॉप शेयरिंग कर दूं.
Okay.
एक बार वो फाइनल वाला मैसेज भेजोगे दोबारा, करेक्टेड वाला.
Welcome, Pankaj sir.
Okay, Shivangi, do you want to ask something? अमित सर, एक बार वो मैसेज भेजना दोबारा.
Welcome, Dr. Kavita.
Good evening, Mitai.
Welcome, Dr. Zulfikar. वेलकम ललित सर, वेलकम मोहित सर.
सर गुड मॉर्निंग सर.
गुड इवनिंग सर.
Good evening, good evening. Mohit sir, good evening.
Good evening, Amit,
Good evening. Good evening.
Rakesh.
नमस्ते सर.
Namaste. Somehow I could make it. I was traveling today from Kathia to
Thank you.
Aligarh.
Sir, it is an important day for us.
Exactly.
For everyone, we are going to also launch today our Airway alert form from our president.
And most importantly, it's another feather on your cap, Amit. Because one by one, you are really going to heights which is unreachable.
No, sir, it's for all. It is everyone's effort.
I know, but someone has to take the lead, no? That's the important thing. I can understand it's a collective effort, but the other thing is who's been after it for a long time.
Yeah, we were trying to do that.
Yeah, so
So today, webinar is on same topic, and we are able to do it.
Yeah, that's the most important thing. So naturally, you need to acknowledge that.
Yeah. डॉक्टर श्वेता मैडम आ चुके हैं क्या? नहीं.
अमित, मेरा एक वो है, आई डोंट मेरा सजेशन है, जो आपका जो डेजिग्नेशन है इन आइडा, आप जब, क्योंकि ये फोटोग्राफ्स आप रखते हो ना, क्लिक करते हो, प्लस आप इसको वेबसाइट में भी लॉन्च करते हो, प्लस आप इसको ग्रुप्स में भी शेयर करते हो, जो ऑनलाइन मीटिंग्स है. I think everyone should put their designation also, even if he's in fact, the chairperson of the meeting. He should write chairperson, and especially you, the post holders, they should write their position. I think that gives an impact, because you're taking the screenshot, or I mean on this meeting. So when you're posting it, you then emphasize that people who are present and who all are there and who are there, what are their designations and what are the portfolios they're holding. So that gives another impact. So I find it, I think you can add to that. That could always be. और एक अगर हम टेम्पलेट बना लें और उस टेम्पलेट के साथ हम रखें, जैसे हमारा आइडा का टेम्पलेट है, उस टेम्पलेट में अगर आप शेयर कर दे तो सब एवरीवन कैन यूज दैट, बिकॉज इतने सारे मीटिंग्स होता है, स्पेशली दिस क्विज. तो वो क्विज का एक मीटिंग जो होता है, उसमें आप स्क्रीनशॉट, उसको आप सब्सिक्वेंट मीटिंग में उसको या तो उसी ग्रुप में आप डाल सकते हो, हु आर द फर्स्ट बेस्ट विनर्स, मीन विनर्स ऑफ दिस क्विज, डालते हो उसके बाद.
मैं हम बाद में कर सकते हैं. वी हैव ऑल द डेटा.
हाँ, सो नेचुरली आप उसको करोगे तो नेचुरली दैट विल हैव एन. हम लोग पहले करते थे कि मीटिंग में हम जो क्विजनर, जो फर्स्ट विनर्स है, फर्स्ट रनर्स एंड विनर्स है, तो उनका फोटोग्राफ भी डालते थे. एक्चुअली वो दूसरे को थोड़ा सा मोटिवेट करता है कि हमारा पब्लिसाइज हो रहा है कि हमने फर्स्ट प्राइज. तो नेचुरली तो दूसरे को थोड़ा सा एनकरेज करता है. दूसरा, that could be an additional point which you can do. So no problem. राकेश जी, आप तो मुझे टाइम ही नहीं दे रहे भाई.
मीटिंग के बाद बात करते हैं सर.
अब मैं देखा कि इसी बहाने में तुमको पकड़ सकता हूँ. पकड़ना तो बहुत मुश्किल है. मैं इसी बहाने में पकड़ सकता हूँ तुम्हें.
अभी बिजी चल रहे हैं सर.
बहुत बहुत, और बिजी चलना ही चाहिए. और हम लोग
Yes,
सबको
sir.
हम लोग सबको बिजी उसको बिजी करके रखना है.
नहीं, बिजी करके रखना है और हमें भी बिजी होना है इनके लिए।
हाँ बिल्कुल, वो तो
सर ये आइडा का है, तो अभी वी विल नॉट डिस्कस
डिस्कस
एनीथिंग
अबाउट,
अबाउट।
हाँ एग्जैक्टली,
दैट्स ओके, दैट्स ओके।
या सर,
बिल्कुल। और कोई आयदा के हैं आएंगे क्या?
गुड इवनिंग सर।
चलिए
गुड इवनिंग सुदेश, वेलकम।
थैंक यू सर, थैंक यू।
ठीक।
So I think I'll just call up Dr. Shweta, whether she has joined or not. Then we can start, Rakesh sir.
ठीक है सर।
मेरे पास क्यों आ रहा एडमिट करने वाले के लिए? आपने मेरे को होस्ट बनाया क्या?
क्या सर?
नहीं, ये मेरे पास आ रहा है टू एडमिट पीपल, तो मैं होस्ट हूँ क्या?
होस्ट है।
अच्छा, आप होस्ट है, सर
हम्म।
ठीक है, ठीक है।
Rakesh sir, can we start?
यस सर।
Madam will join.
ठीक है सर।
So welcome once again, all the airway enthusiasts across India. Thank you so much for joining today. Today we are on Quizinar number 10, and it is a very important landmark. This is in our Aidaa guideline series, fourth Quizinar, fifth Quizinar rather. We have done adult, pediatric, obstetric, and then extubation. In all our guidelines, there were some important concepts which require further clarification and deliberation. So for that, we have published a separate paper on our code, difficult airway card, and airway alert card. So to deliberate upon that further, we have our speaker, Professor Dr. Rakehs Garg from AIIMS, New Delhi. He is current president-elect of All India Difficult Airway Association. He is chief editor of Indian Journal of Anesthesia, and he is well known across India. So today's program will be like he will be taking us through this important concept of our code, card, and alert. Then we will have a session where we are joined by our esteemed chairpersons. Our esteemed chairpersons are Dr. Sudhesh Kannan, Professor of Anesthesia, BMCRI, Bangalore. He has numerous publications. He is treasurer of ISA Bangalore Metro Branch, immediate past editor of Karnataka Anesthesia Journal, and recipient of ISA Presidential Award. and he is also very well known across academic circuit in anesthesia. Next is Dr. Pankaj Gupta, National GC member from 22 to 25. He is a private practitioner from Nasik. He is national head of PPF of ISA. So private practitioner forum is something which is sort of his brainchild, and he has really done a lot of hard work for bringing this private practitioners forum in Indian Society of Anesthesia and in entire India. He is also sub-editor of Journal of Anesthesia and Critical Care Case Report, former president of ISA Nashik and IMA Nashik, vice president of West Zone ISA, faculty at multiple national and state conference, best publication award, and he has expertise in pediatric neonatal obstetric and laser surgeries, joint replacement anesthesia, and also planned a Kumbh Mela disaster management in Nasik. Welcome, Dr. Pankaj Gupta.
Thank you, sir.
We have Dr. Zulfikar Ali, who is additional professor in Division of Neuroanesthesia Scheme, Srinagar, Jammu and Kashmir. So he's in charge of Neuro ICU, course coordinator of DNB, Neuroanesthesia and Critical Care. He is executive committee member of Indian Society of Neuroanesthesia and Critical Care. He has been our executive committee member and treasurer of Aidaa. He has hosted 2 national airway conferences in Srinagar. He is section editor of IJA, co-editor of textbook of Neuroanesthesia and Neurocritical Care, and recipient of ISA Presidential Award. Welcome, Dr. Zulfi.
Thank you, sir.
Next, we have Dr. Shweta Salgaonkar. She is professor and anesthesial pain consultant at SIT, ESMC and KEM Mumbai, Maharashtra. She is professor in anesthesiology, facilitator of vital anesthesia simulation training, fellow of Indian Academy of Pain Management. She runs MUHS recognized fellowship course in pain medicine since 2016. Has done advanced course in medical education, past associate editor of postgraduate Journal of Postgraduate Medicine and Indian Journal of Pain, multiple publications, and her one of her active interests is difficult airway management. And last, we are joined by Dr. Kavita Lalchandanani. She's head of the department at Baroda Medical College and SSG Hospital, Vadodara. And she is current president-elect of Gujarat State Branch, Indian Society of Anesthesiology, has 30 years of teaching experience, has published her book, Application of Ultrasound in Anesthesia. She is faculty and course director at various places, organizing secretary of various conferences and numerous publications. Welcome, Dr. Kavita. So our program would be like this. So we will be, Dr. Rakehs will take us through this important concept, followed by discussions and if there are any queries, will be solved by our esteemed chairpersons and our speaker. Our chairperson can also give their input. Followed by what we would like to do is to release our airway alert form. Okay. This was a project which we have decided we wanted to design. So today is the right time. We are going to launch our airway alert form, wherein you can fill in your information. One important problem in airway alert is that the next anesthesiologists do not have adequate information about what went wrong in the last whatever airway management. So here it would be generating a QR code which can be shared with the patient. So whenever patient goes to next doctor, he can just show that QR code and the doctor can identify the problems which was faced by the previous anesthesiologist. And then followed by a very interesting concept which we are running since our 10th Quizinar, the kahoot quiz, where everyone can join on the similar subject. So on that note, welcome again to Aidaa's Quizinar series. This is in the run up to our National Airway Conference, which we are hosting with International Airway Management meeting in New Delhi at AIMS on 9th, 10th and 11th October. Thank you all. Over to Dr. Rakehs, sir.
Thank you so much, sir. Thank you so much for today's.
Yes, sir. You can share. Yeah.
Yeah, thank you so much, sir. Can I start, sir? With your permission?
Yes, please. Yes, thank you, sir. Yes, please.
Right. So in this series, we are continuing. This is all the 10th webinar of the Aidaa and 5th webinar of the Aidaa guidelines that was released into November 2025, the updated guidelines of 2016. And we have already discussed the guidelines which are related to the airway management for the adults, for the pediatrics, for the obstetrics. We also discussed about the extubation guidelines. We are working on the critical care guidelines, and this will soon be coming up. But when we talk about these guidelines, we also need to understand that when we talk about airway management, we also need to understand about the difficult airway equipments, which should be kept in certain systematic way so that they can be effectively used as and when required. The other concerns remains the call for help, and the Aidaa comes up with something innovative and making it code D so that this becomes more focused. And having said that, if a patient is having a difficult airway, the patient may require airway management in future, what to do about it. And that's why, again, Aidaa comes up with something airway documentation, airway alert documentation, issuing a card and documenting the file. So next around 20-25 minutes, I will be taking through the important aspect of Aidaa guidelines, assembling a difficult airway card or a kit, which is again a new thing, declaring code D, and issuing an airway alert card for unanticipated difficult airway management. I bring greetings from All India Institute of Medical Sciences. Now, this is how the Aidaa guidelines has evolved from 2016 to 2025. Which was a major change, not only from the robust methodology of the Aidaa guidelines, involvement of appropriate systematic reviews, meta-analysis, a very stepwise approach of the Delphi. And with this robust plan of the evidence analysis and use of consensus wherever required, Aidaa has made a remarkable change in the robustness and the applicability of the Aidaa 2025 guidelines. If you see how they evolved about 2016 to 25, we have been talking about the failed primary airway plan from the beginning itself. The Aidaa has shifted from linear approach or a stepwise approach for the management because there have been an evaluation of different equipments as a primary plan, and hence linear approach may not be applicable for all patients. And considering this, Aidaa came up with circular interchangeable rescue model. Generic call was shifted to code D because call for help inside the operating room could be for many, many purposes. And it has to be focused when we talk about airway management. And that's why Aidaa proposed that code D would be a better option. And same will be the surgical airway, which has to be as a part of rescue plan when there is a complete ventilation failure. And also the Aidaa 2025 guidelines has put a lot of emphasis on the human factors. Because learning a skill is important, we agree, but simultaneously various system factors are also involved, which is interrelated with human factors for a successful airway management. And this context, we emphasize that today's session will take you through some of the important aspects. And this philosophical shift, which has happened because of the evolution of the evidence with the synthesis of evidence in a very systematic way, Aidaa probably is more focusing on oxygenation over intubation during the intubation attempts. And airway rescue is not a hierarchy. Basically, it's a circular one, and people can choose. It's not always that step one is a tracheal intubation and then the supraglottic airway device. But yes, nowadays we are using supraglottic airway device for routine airway management. So the goal here is effective ventilation plus oxygenation. And it is not just a tracheal intubation because many patients, maybe it differs from person to person, but 30-50% of patients may be under awake sedation techniques under regional anesthesia, or they may be requiring a supraglottic airway devices, and hence interchange needs to be done. And that's the key philosophical shift that has happened in these guidelines. Now, talking about these guidelines, if you see the management of an airway, a successful, uneventful airway management probably requires a control. If we are struggling, if we are having an airway crisis, we have to shift from crisis to control. And the presence of guidelines are important. But in all the guidelines that has come up, three main pillars, which is giving strength to those guidelines of the Aidaa 2025, is the preparation, call early with prompt assistance, and documentation. And this is what Aidaa came up with a separate paper of a difficult airway card and kit, code D, airway alert documentation, and issuing the card. And these three pillars I will take you through. So let's come up with the paper which has been published in the November issue of 2025, where all these three aspects has been taken care of. So I will try to cover in next around 20 minutes about the difficult airway card, about the code D, and about the documentation. Now, when we say three pillars of the safe airway management, why this Aidaa came with this proposal of making a separate paper? So when we say the preparation, yes, definitely understanding the approach, the strategy. It also requires availability of a difficult airway card, and that is a part of our preparation. That is one of the core pillar. And if we prepared, it prevents crisis. Now, even if you are managing airway, sometime we need helping hands. Sometimes we need an expert hand if you are struggling, because we all are having different experience. And that's why our call early is code D, which has to be very specific, and early call saves lives. And third pillar, document. Now, when we say documentation, if we have struggled in the airway management for a patient on a particular day, the patient may require repeat surgeries. For example, those patients who are, say, COPD patient in ICUs, or who are requiring oncologic repeat treatment management. So this means we have to document today to save tomorrow for a better airway management. And this is what the three pillars are, and that we'll be taking through. Now, why this Aidaa frameworks matters? Now, when the airway catastrophe happens, at certain point, with inclusion of these three pillars, we can prevent morbidity and mortality. And a NAP4 study which talks about airway complication, almost 40% contributed to human factors. And any delay in the decision making will lead to more dangerous morbidity or a mortality of a patient than just lack of equipment. So this means we need something which is standardized, which can be communicated early with rapid escalation, team preparedness, and documentation system. And that's why Aidaa took cognizance about this aspect, and that's why a separate paper was published which emphasizes on these aspects. So this is what we have to think of when we talk about the management of difficult airway, that we have to prevent somewhere the airway disaster chain. And this is what, if we can prevent a failed attempt, if we can prevent a delay, if we can prevent a desaturation, we will prevent a panic, we will prevent hypoxia and a cardiac arrest, hypoxic cardiac arrest. And this is what these preparedness, call for help, and documentation. So this is, we have to break this chain of the disaster during the airway management so that we can manage these patients more effectively now and later on as well. Now let's come to the first important aspect, which is called code D. So this is what the symbol was provided by the Aidaa, which is a sacrosanct symbol wherein the presence of this symbol or announcement of this code D emphasizes certain important aspects. And when we say the code D, basically we are looking for crisis to control so that expert help comes to us. Now code D means the hospital emergency code indicates difficult airway requiring immediate assistance by a trained staff. And the D stands here for difficult airway. And code, everybody knows that when the code is activated in the hospital, whether it's code blue or a code orange, this means it is something very, very urgent or emergent. And that's why once somebody announced code D, D means difficult airway. So this means there will be a designated mode for summoning help from a trained staff who is well understood for the various aspects of airway management. Hence, we are becoming more focused. If you don't announce code D and just say call for help, what wrong will happen? We can say, okay, call for help. But think, call for help inside the operating room, many things. It could lead to delay. It may be, people will think that patient is having some issues, some other problem, machine problem, or a regional anesthesia problem. There will be ambiguous communication. panic can happen because some people or many people will come, which may not be the absolute requirement of the patients with difficult airway. No mobilization system, equipment availability, cognitive overload, because many things are happening together. So this means until and unless we announce a focused call for help, we will struggling with these problems. But if we apply a focused call for help, it's standardized, we get a rapid response. It's a situational awareness. That's the most important aspect. The person entering into the operating room understands, is aware of what is happening, and he has been called for managing a difficulty. And it improves the coordination. And that's why when we announce something, the call must be specific. It must be purpose-oriented. It must be prompt. It must be clear. It must be context-specific. It must be time-sensitive. It must be standardized. And that is what Aidaa thought. Why not to introduce a term called Code D, so that all these features, when we say an effective call for help, an optimal call for help, every these features should be part of it. And that is what stands for Code D. If you see the algorithm also, it has been very nicely mentioned on one side, call for help as Code D, so that it becomes more specific. And this Code D, call for help Code D, is uniform across various guidelines. The Aidaa has released the adult guidelines, pediatric guidelines, obstetric guidelines, even the extubation guidelines, and every feature will have a symbol for the Code D, which is call for help for the difficult airway management. Now, when to declare Code D? If you see the algorithm, which is there on the right down corner, the call for help is across the airway management. So we are not looking for a specific step, and being a circular algorithm, we should be very cautious. So this is the first difficulty encountered during the airway management. Since we are having a circular approach, we may be going for the second and third device as a rescue. But the moment we feel that the patient, at the first instance that this patient, we are having some struggle, some difficulty during airway management, I think that's a trigger for declaring Code D. Okay. And Code D does not mean that this is the last point when the patient starts desaturating or a hypoxic cardiac arrest or failed multiple attempts. Not at this point of time, because we will need some time, people will need some time to come. And that's why first difficulty encountered during airway management must be the trigger for declaring the Code D. Because early escalation saves lives, time is precious, though we are also emphasizing, as was discussed in the previous webinars on the guidelines, that patient must receive oxygenation during the whole process of airway management. The patient may not desaturate, but still, if you find a difficulty, patient may have some issues, and we should be very cautious in managing that. And that's why thinking this aspect, the terminology has its own relevance. We don't have to wait for cannot ventilate, cannot oxygenate situation. We don't have to wait for cannot intubate, cannot oxygenate situation. What we have to do is, we have to make Code D as a trigger whenever we have a complete ventilation failure at any point of time, or we are facing a difficulty at the first step itself. And that's why ventilation failure occurs before the oxygenation failure happens. And that's why we must remember that Code D activation should not be when the patient starts desaturating. It should be when we are struggling with the air, when there is a complete ventilation failure. So do not wait for severe hypoxia before the surgical airway. Do not wait for hypoxia to happen if you have find any indication of a difficult airway, even at step 1. And that's why you have to declare or trigger Code D here. And especially when there are high risk scenarios like head and neck cancer, morbid obesity, obstructive sleep apnea patient, airway trauma, burns, pediatric anomalies, patients in the ICUs with swelling, infections, edema in the head and neck area. Here, the Code D activation should have a very early moment you realize that something is wrong. And how to operationalize it? Whenever you find airway difficulty, just announce the Code D. And airway team is mobilized, difficult airway cart is arrived, surgical ENT or surgical emergency critical alert backup is alerted, and the crisis documentation initiated. This is how we have to follow the step when the circular algorithm of Aidaa guidelines comes into picture. Now, this is what I have said in the last 5 to 10 minutes. So when we talk about Code D, we should be cautious. We should declare at the first difficulty. We should declare before the oxygen deteriorates. We should declare at the first instance of facing a difficult airway, or a complete ventilation failure. Whether we talk about adults, whether we talk about obstetrics, whether we talk about pediatrics, whether we talk about extubation. So we should be very cautious when we talk about these aspects, and hence we should be taking care of these features as early as possible. Now coming to the next aspect, when we see these equipments, when we see these carts, when we see these bags, again, they becomes important from crisis to control. When we say crisis to control of difficult airway, we need different equipments which is strategically arranged. You remember, if you have a cupboard and all the books are staggered here and there, and if you want to search a book, it will take some time, isn't it? So why not to arrange even the difficult airway equipments into some compartmentalized system, so that if you are struggling with something, we can use them more effectively without wasting time. And whole group of equipment are compartmentalized as per the patient's requirement. And this is what the need for having a difficult airway cart. And when we talk about managing airway outside the hospital, outside the operating room scenarios, anesthesiologists are involved in those aspects also. Difficult airway cart may not be there, especially in the wards or peripheral areas, though it should be, but it may not be available at all places. And in those situations, carrying the cart will take more time. So why not to use a carry kit? And this carry kit will have minimal equipments, but all essential, which are important for this. So difficult airway cart was proposed by Aidaa into such a compartmentalized way, so that setup has a dedicated, organized, mobile airway management system for managing anticipated or unanticipated difficult airway, and it aids in rescue airway management or emergency surgical airway management. And it benefits. How it benefits? It has a structured response. It reduces cognitive load. It has a faster access and rescue. It's a better teamwork. It improves the outcome, and it minimizes the chaos also. So we should be very cautious when we start managing this difficult airway, because the difficult airway cart, the core principles should be that uniformity. If an anesthesiologist is working in a hospital, if the type of equipments arranged are in different OTs, operating room, or the working area, probably they will struggle to find an equipment in the time of an emergency or a crisis situation. So the principles remains uniformity, accessibility, logical organization as per the strategy, clearly labeled drawers for compartments, portable, checklist-based talking, we need to check it, and checking system that they are functional. So these are the principles of our airway cart, which has been proposed by Aidaa, which will definitely improve the success of our airway management. So what we have affirmed during the difficult airway cart as per the Aidaa guidelines, it should be standardized. So consistent layout across all operating rooms. Modularity, compartment organization according to plans or the steps of the strategy. Portability, mobile cart, because they have to be moved from one place to the other. Accessibility, so dedicated mobile cart with labeled compartments. Readiness, all equipments must be checked daily and in a functional situation. Redundancy, we don't want to keep multiple things. Say if you have, say, 10 different type of blades, should they be kept there? You always are using laryngoscopes onto your operating rooms, on the operating trolleys, on the anesthesia workstation. Do they need to be kept there? So anything which is not exactly part of your strategy may be removed, and they may be kept at different places so that they are not causing cluttering, and you get the equipment at the right time wherever required. And finally, documentation, which is again very important. The compartment organization of the difficult airway cart by Aidaa, it ensures that airway management equipment, including adjuncts and surgical, is arranged in a structured manner. But then definitely each equipment's availability will be different in different hospitals. Somebody will be using one brand of blade, other will be something different. They can be adapted to meet local, regional, or institutional needs, but they should be uniform in that particular institutes. Nowadays, many of the equipments comes in their ready-made trolley. For example, say bronchoscopes or video bronchoscopes or video endoscopes or video laryngoscopes. They come into our trolley where they are fixed into that. So those may not be unlocked from there and kept into the cart. They may be separated. So depending upon the institutional needs, they can be kept there. And as mentioned earlier, the routine airway management equipments like laryngoscope, tracheal tubes, supraglottic air devices, they are being used routinely for all patients. So they may not be part of mobile airway cart as such, difficult airway cart, because you are using them routinely, and that's why they may be kept separated just to decongest them. Now, this is how the compartmentalization has been done as proposed by the All India Difficult Airway Aidaa guidelines published in November 25. The compartment one, the strategy is here mass ventilation, and hence you should have bag mask valve with reservoir bag with oxygen tubing. This is important. The nasal oxygen devices like nasal cannula and high flow nasal cannula, again very important. This should be part of your compartment one. Compartment two is tracheal intubation and aids. So it includes the face mask, the oropharyngeal airways, the nasopharyngeal airways, laryngoscope, handles and blades, video laryngoscopes with hyperangulated Macintosh, flexible video endoscopes, airway introducers like stillets, Uzis, airway exchange catheters, tracheal tubes like curved and uncurved, and suction catheters. Remember, when I'm just summarizing these devices, depending upon the type of operating room, the sizes, different sizes should be available as per the requirement. And the devices which provide nasal oxygenation throughout the airway rescue may be in any of the compartment, because we mentioned in the beginning itself that oxygenation must continue during the airway management. So they can be kept at any place. Compartment 3 dedicates to a strategy of supraglottic airway. Aidaa suggests that, proposes that you should use second generation supraglottic devices with introducers or insertion aids for faster placement. Tracheal tubes and airway exchange catheters like entry catheters, which is sometimes required for intubation through SJ devices, should be there. And the compartment 4 should be for surgical airway and specifically for emergency cricothyrotomy. It should have all the equipments which is required for surgical cricothyrotomy like scalpel blade, Uzi, and tracheal tube size 6. It must be a part of it. Sometimes needle cricothyrotomy is used, so you have cannula. And when you use cannula, always remember manual jet ventilation system is required. Now, these are part of the difficult airway cart. But when you want to carry it to the different places, we cannot put all those equipments into a carry cart, carry kit, or maybe in the form of a backpack or a hand-picked bag. So the last column shows what should be the equipment. So mass ventilation, there should be a bag wall mechanism, bag wall mask with reservoir with oxygen tubing. For the compartment 2, that is the part of tracheal intubation. It should have the airways with laryngoscopes, with tubes and suction catheters. And compartment 3 will have any one of second generation supraglottic device of appropriate size. And compartment 4 should have surgical cricothyrotomy kit, which contains cervical blade, Uzi, and tracheal tubes. Now, having said that, when we say airway management is just not equipments for airway. It should also have medications, airway agents, monitors, and sometimes when you are taking care of a special group of population, it should have, say, pediatric specific or obesity specific or obstetric specific or extubation failure kit. They should be there depending upon the need. Medications, it may be a separate crash cart or maybe a separate adjunct, or they can be part of the hanging on the cart itself. Adjuncts, when we talk about the devices, the bite blocks, the McGill forceps, nebulizer mask for awake intubations. So these are the adjuncts that should also be considered when you are discussing about the complete presence of all the things which are required for airway management in a successful way. Those operating rooms which caters to a specific population, like a pediatric operating room, or where obesity surgeries are being done, or an obstetric area. In those situations, there can be an extra drawer or a compartment where a specific equipment or size-specific equipment should be there in the cart, kit, or an additional compartment that can be used depending upon the need. And that's why we said it can be, depending upon your local requirement, it can be adapted as per your need also. Now, this is what we talk about carry kit. We already discussed about the contents into this. These are usually for airway management, successful airway management outside the routine operating room areas like ICU, ward, MRI, cath labs, ambulance, transport wards, and other places. Though in ICUs, we still prefer that we should have a difficult airway cart because it's actually a difficult airway, not anatomically, but at times physically also. So, but when we say carry kit, as I mentioned, it should have minimal but essential airway management tools so that they can be easily carried without cluttering. And these are devices which we have earlier, depending upon the strategies we have listed earlier, and they are published in the guidelines as a tabular format also. Now, how can we implement the effective use? Now, when we say the use of difficult airway cart, people, depending upon the type of difficult airways, the equipment may be used. Sometimes they may be not functional. So the inventory and usage log must be maintained. If you use the difficult airway cart, ensure that there are any items which has been used is replaced. Check for the functionality. For example, say the laryngoscope battery is okay, the laryngoscope battery is okay, they are functional, the cuffs of the supraglottic airway devices are not ruptured. So check for them, their availability and functionality. And a person should take a responsibility who has checked it on a daily basis. Also, once they have been used, subsequent to it, it should be, the log should be checked for replacement of the existing thing. Now, again, from crisis to control, we have done it through using this strategy. But these, when the patient comes for again, we need to issue them airway alert document, a difficult airway reporting form, and airway alert card, so that if these patients require some intervention subsequently, they can be managed. And this is what a standardized difficult airway card, which is the minimum requirement that needs to be documented for a person who will be giving anesthesia and airway management subsequently. These basic components should be there. Not only this, if you see at the base of or the lower part of the airway, difficult airway alert form, it is mentioned that the patient should understand for what reasons it is providing. It's very clearly, dear patient, the anesthesiologist take care of you during your recent surgery, face a situation of difficult airway. For your safety during any future surgeries, it is important that you inform your doctors and anesthesiologists about this event of the difficult airway. Carry this card and share it with your anesthesiologist and critical care physician before any surgery. And above will be the informations that will be carried upon by the patient so that they can take care of it. And it needs to be attached to the patient file also if the patient is coming to the same hospital. And I think the provision of this difficult airway alert form should be very standardized and should be approachable in some form, which should be given to these patients so that they can take it. So the patient alert card is important for patients who may need future surgeries, ICU airway management, extubation failure, and reintubation for emergency airway interventions. And it prevents recurrences of difficult airway because we are pre-planned. We know what exactly the problem was. Improves future planning and patient safety continues. It should be difficult. It should be issued whenever there's a difficult intubation, there's a failed airway, there's an emergency surgical access, there's a difficult mass ventilation, a difficult supraglottic airway. Any difficulty, issue them an airway alert card. And it must include the contents which has been standardized. And this is also, a standardization is important because when we say a card is standardized, the alert is standardized, it becomes easy for subsequent management. And that's why Aidaa has come up with standardization of the airway alert card also. And what should the patient be told? They should be clearly instructed that for this purpose, this was the problem with you. There was a difficult airway. And whenever you go subsequently for incidentally any mishap or any redo surgeries, do inform your doctors about this and carry your card. This will also be put into ICU notes if somebody is using the online mode of entering it, electronic medical records, put them up. It should be a part of a discharge summary also, so that we are using all resources so that this catastrophe should not happen by just simple documentation. And we are sure, and Aidaa is taking for these initiatives that QR-based airway alert cards and registry should be a part of airway management, and it should be a part of airway data collection as a part of registry. And you will get some good news about this initiative from the Aidaa very soon, and probably the accessibility will become better. Having said that, when I talk about the cart, the kit, the code D, the human factors, which we have discussed in the previous guidelines also, we also need to understand that keeping these equipments will not lead to the successful end. What we need to do is, now is the era of simulation training, and we should simulate even for these aspects, how people respond for code D. As we have been doing for code blue, people should summon, moment they activate code D, what help, how they will arrive, who will bring it. So all those should be simulated into a scenario as a part of mock drill, and role allocation should be clear. Failed airway drill should be done. Cricothyrotomy should be practiced, a simple measure. And human factors training, again, a very important factor which has been highlighted very strongly by Aidaa in their guidelines. It should be a part. And we should do a routine simulation, understanding and training and drill so that we remain acquainted for a life-threatening event of a failed airway. If we can do it, we will improve and our success will improve. So this means Aidaa 2025 airway management guidelines is not just an airway algorithm. It's just not a stepwise approach or maybe in a circular fashion. It is much more than that. And I will strongly suggest just go through the airway guidelines, which has been published by Aidaa in 2025, because it is a systems approach. Aidaa has emphasized on the safety approach, on the communication approach, on the preparedness approach, and documentation approach. So this whole system is a system of safety. The whole system is a system of uneventful airway management, even if it is unanticipated difficult airway. Following these norms, probably we would be avoiding many of the events which will be catastrophic, which can be associated with morbidity or maybe the mortality. So Aidaa 2025 airway management guidelines transforms airway management from an individual procedure, from an individual skill into an integrated safety system and a strategy. And this is what is required for successful airway management. So let's come up with the various airway management guidelines and integrate difficult airway card for preparedness, code D for rapid targeted response, and alert card for future safety. Difficult airway outcome improves not merely with devices, learning skills, but by systems, preparedness, communication, and documentation. And this is what Aidaa has taken a long leap to prepare the whole document as a part of the Airway Management Guidelines 2025, which are available. You can take a screenshot of these QR code of the Airway Guidelines, which are available. They can be downloaded freely from the journal, and you can read it full. So these are the QR codes. You can take a snapshot. And I'm also bringing the next QR code for the other guidelines. You can take a snapshot. You can just scan it and you will have access to the full airway management guidelines by the All India Difficult Airway Association 2025 Airway Management Guidelines. Thank you so much. And once again, we welcome you for a global airway meet, which will be happening from 9th to 11th October 2026 at AIIMS, New Delhi. It's for the first time, it's a collaborative conference of All India Difficult Airway Association along with International Airway Management Safety, International Airway Management Team. At 9 to 11th, we have almost more than 35 international faculties coming and more than 150 national faculty, many workshops, many master classes, many videos, many panel discussion, and many faculty of repute will take you through the safe airway management, whether we talk about skills, whether we talk about strategies, whether we talk about experience. So most welcome, 9 to 11th October, NAC and IM 2026, AIIMS New Delhi. Thank you so much, and over to the chairperson.
Thank you, Dr. Rakehs. And, the best way to understand any subject or any concept is from the person who has written it. So, lead author of this particular paper on airway, card, code, and alert, Dr. Rakehs. Thank you so much. Now, floor is open to the chairpersons. I once again welcome Dr. Pankaj, Dr. Shudis, Dr. Kavita, Dr. Sweta, and Dr. Zulfi. First, any comments on this, and then we will open house for the further discussion and query session. Dr. Pankaj, sir.
Yeah, Dr. Rakehs, that was an extremely superb talk on some of the very basic things that most of us, especially those in private practice, are not really well prepared with all gadgets and all the hi-fi things that most of you have in institutes. So when we came out with this position statement last year, what we had done was we had tried to give highly recommended and recommended suggestions, or recommendations rather. So what we had mentioned in our position statement was highly recommended. We insist on having an intubating bougie, a supraglottic airway, a McCoy blade, and a Cricker thoracotomy set. And of course, a 14 to 16 gauge needle. This is what we have said is highly recommended. And in the recommended guidelines, what we had suggested an intubating LMA is a must. Video laryngoscope is necessary, and a fiber optic intubating scope. And I feel with this code D, I feel things are going to be very easier in the future, the way the questionnaire that you have prepared to be filled in by anyone having a difficult airway, I feel having a QR code is a brilliant idea. Because I mean, if the what I understood from the talk is that the QR code probably will just be scanned by anyone, any patient, and if case the patient has an history of a difficult intubation, probably that particular anesthetist will get it. Am I right, Dr. Amit? That's
Yes.
how it is.
Yes,
sir.
yes. So
Wonderful. That's a
it will be
wonderful,
shared with
wonderful
the
concept.
patient. Yeah,
Yeah, that's an
it
excellent
can be
concept.
shared
I
with the
mean,
patient.
yeah, because we do come across these sort of patients very often, and most of us are taken up by surprise, and especially us practitioners have to be very, very careful, and that's why we have to keep upgrading our operation theaters as much as possible. I feel with that I will conclude. It was a brilliant talk, Dr. Rakesh, as always. Thank you.
Thank you, sir. Dr. Sudhis,
Unmute yourself, sir.
Dr.
Sudhir, sir,
Sudhis.
Yeah, sir. Good evening, sir. Good evening, Amit sir and Dr. Rakesh. It's been a splendid presentation, and this concept of having a code, declaring code D and having a airway difficult airway card, I think it's one of the most innovative ways what we have seen, and it's an excellent step towards preventing catastrophe for the future management of patients. In this regard, the way the systematic management of difficult airway card has been proposed seems to be quite comprehensive, and it's not limited. It is though it is comprehensive, it encloses all the device whatever we can use, right from the basic devices till the most advanced devices. Everything are included in that, and that stepwise arrangement definitely goes in a long way. I think many people are already following and bringing some sort of a standardization in this through our guidelines. I think that will go a long way in standardizing a work condition wherever they go. For example, especially as Pankaj sir was saying, so suppose if somebody is attending multiple hospitals as a freelance anesthesiologist, if there is a standardized way how the devices are kept, he need not run around from pillar to post searching each device in different hospitals, because there is always a tendency for each different hospital to have a their own way of arranging things. So if this standardization protocol has been, if it is followed among all the hospitals, this makes life much more easier for all those freelancers, because they are always time pressed, and many a times it so happens that they are going to a hospital which is not familiar to them. Sometimes they are going to the hospitals which are occasionally calling them. So in such situations, when I come across unanticipated difficult airway, I think this is going a long way to help them sort out the issues, as well as uh, prevent future catastrophes by giving this card. I think all those things, I think validation aspect, everything would have been done before publishing. So therefore, there's no question of confusion or any this one with regards to either the card nor the card. I think that's to sum up. I think this is a wonderful presentation and a very solid concept what we are bringing out through Aidaa.
Thank you, Dr. Sudhis. Dr. Shweta, what is your experience in your institute, and how would you like to incorporate? Most of us have airway card, right? But like what we are trying to do is to make it systematic so that there is a uniformity. Not necessary that every institute will have absolutely same equipment, but there would be uniformity in how it can be organized, and the standardization can occur. Your experience, Dr. Sweta.
Yeah. So good evening. And yeah, it was a great presentation by Dr. Rakesh, highlighting all the aspects of difficult airway management from crisis to control with a standardized protocol, uniform preparedness, communication and documentation, extremely important. And great work done by Aidaa. This is all about the patient safety, and healthcare is a partnership increasingly. So definitely working towards patient safety, especially for the anesthesiologist who is working from behind the curtains, it's extremely important. Coming to this, yes, uh, uh, being in a public teaching hospital with a varied super specialties and specialty surgeries, and so the anesthesia that we are providing, there is a lot of variation in the experience of the conducting the anesthesiologist, and even the teaching is happening. So the residents are there of all cadres, right from your first year to SRs to professors. So there is different in the skill set of everyone. There is difference in the experience and the kind of surgery, the patient population. It's all going to be very varied. But one protocol, if we keep this standardized, it can really curtail down a lot of unanticipated airway and the consequences. The airway you can still come across unanticipated. That incidence we may not be able to reduce, but the patient outcome and the safety that can happen with this standardized approach, that as the paper talks about the having the kit and how the team, the code D being activated. They should have these people in place who are expert and who are simulated, trained all the time, so that the reflexes are very sharp, and this has to happen in a very short span of time. Like within 3 minutes, we should be able to get back to the ventilation and oxygenation. So with the standardized approach, with the minimum local, depending on the patient population and the local guidelines that we can form, and we can modify it to our need, keeping these basic guidelines which are given by Aidaa in mind. One thing I wanted to ask about this reporting form, if Dr. Rakesh or you can answer this, that we talked about the difficult airway, the form that said it does not mention about whether the patient was awakened or was reversed with Sugamadex, or you think is it important to make a mention of that?
Ma'am,
That is
we will go through the structure of airway alert form. Okay.
okay.
The concept right now is to identify whether this problem was anticipated or unanticipated. What were the strategy which was used? What were the strategy which were failed? What were the strategies which were successful? And what was the outcome? Now,
Yeah.
at every step, there is an option to comment further or to add your information further. To make
Okay.
it very specific becomes very difficult and people may
Yeah.
not fill up.
Yeah.
So right now it is in the format where a general information is passed on to the next anesthesiologist, who, if he wants to identify whether this was there any difficulty previously and what was the nature of difficulty, so that he can make sort of an informed decision. But this would be an ongoing process. We can modify it further. We can add any information as we process and as we progress. I think things may change. Dr. Rakesh.
Basic purpose of this alert is we do not want to give a cognitive overload. Each institute has its way of management. So basically, we are not saying the other institute, you manage my way. So we should be clear. And the basic dictum in the airway management is follow the technique, use the equipment which you know the best. So we are not saying if somebody does not have a Sugamadex, they will feel. So if you see the content, as Dr. Amisha just mentioned, they are the minimum but essential requirement for anybody to stratify and make a plan. So we are stopping there. Plan may not be the same. For example, if they have reversed with Sugamadex, they will not try to give rocuronium, have a difficult airway and reverse with Sugamadex. What we want is they understand it was a difficult airway. Maybe this time they will plan with the awake airway management. So we are giving the concept here, not the strategy to follow the same, because each will have different expertise. That's the basic principle of airway management, and we do not want to clutter it. Yes, we agree when we were framing it, it was a 3-page form initially, but
Yeah.
then everybody said cut, and then finally we reached one way. And this is what the consensus was.
Yeah. One more question, if I'm allowed to ask, whether this can increase medico-legal issue. I think one of the participants is also asking the same. So, are there any concerns about that? We put up things here on paper in detail.
So, madam, it is very clear. Nowadays, there is nothing called the most of the cases. Dr. Pankaj Gupta will also emphasize most problems happens with lack of communication and lack of transparency. If I face a difficult airway, if I have broken a tooth of a patient during airway management, accept it. It was a difficult airway, tooth was broken, and this is the tooth that we have given to you. Because subsequently they will find it out. They will find the reason. They'll find an airway trauma. So we are just clarifying it. It's not just documentation. If you see the airway management guidelines, the last column says document and follow up the patient while the patient is admitted. And when we say follow up, explain them everything. It's not just document, explain that you had this problem. And once you explain them, they will be thanking you so much that you have saved their life. And we should be transparent.
And with the digital electronic records nowadays, it's everything is captured right there. So it's always better to be transparent, and audit should be there, so that can help.
Yes.
Yeah.
So the
Thank you
idea
so
behind this, the idea behind alert form would be that, if I have faced a problem, next time if that patient undergoes another anesthesia, the next anesthesiologist should be aware that, okay, there was a problem last time. Right now, we do not have that information ever. Right? My patient may have undergone 3 anesthesia. I don't know whether that was a smooth anesthesia. Was there any airway difficulty? So history of previous difficulty is something which is very difficult to get, and patient is obviously not going to understand it. So the idea behind this is to create an alert, and patient will have a QR code. And if he wishes to share to the next doctor, he can do it. Okay. So this should be shared by, so the form would be filled up by the anesthesiologist or the hospital administration. If they wish to share this with the patient, they can share with the patient. So again, it will be shared with the patient. The person or the patient will decide whether he wants to share it further with anyone else or not. So it will be, again, it is not mandatory. It will be, if doctor or the hospital wants to share, or if he wants to share information, then only he will fill up the form. So those medical legal parts should not be an issue, I suppose. Any other comment on this, sir? Medical legal aspect. Okay. We'll move to Dr. Kavita. Dr. Kavita, your experience of
Dr. Amit,
such format.
Dr.
Yes,
Amit,
sir.
And actually, my point, I mean, what Aidaa wants to say is, actually, whatever you are thinking of medical legal aspect, the most important thing is, what was your intention? The intent has to be for saving the patient's life. So whatever you've done, if the intent was to save the patient's life, the medical legal aspect can be dealt easily. And that is what is needed to be proved. And whenever you talk about medical legal aspect, naturally, when you document anything, that itself says that you are very clear and transparent. And that is what Aidaa has always emphasized over the years, last 10, 15 years. Aidaa has been very clear in it that how to prepare yourself, how to prepare the patient, and what are the things which are recommended, and what are the documentations which are needed to be done. Very categorically, Aidaa has emphasized on this. And this was something which was, and code D and alert, airway cart alert, airway alert cart is something which has now, that Aidaa is emphasizing more deep into it, more critically trying to analyze it. And that is what we are trying to make people aware. And you see, over the last 10, 15 years, people are much more aware of airway, difficult airway, and how to prepare and what are the things you need to document. Over the last 10, 15 years, Aidaa has been trying this, and we are really happy that we have been successful in, probably we have been successful to achieve that target we were trying to do. That's what I was talking.
Dr. Rakehs just mentioned about loose teeth. I feel what can be included in the guidelines is having a teeth guard. This definitely, especially for suspension laryngoscopy, we always use it because invariably most of these patients have a loose tooth. And of course, many times we inform the patient well in advance that you have a loose tooth, it may just come out, especially in suspension laryngoscopy. So, and post-op, it has happened that patients, the tooth has just come out, and we hand it over to the patient after it with proper documentation. So it's very important. Medical legally, usually when you're truthful to the patient, there is no problem. But I just thought this teeth guard can probably be mentioned in some way in the guidelines or in some way. Just came to my
That is
mind.
what he said, that is what Rakesh has said, that there are certain things which are silent. It depends upon whatever things you are available, it's available with you. So that is what he has tried, and that's what I was saying. As Rakesh, it's always been really, I mean, it's a privilege to hear him. It's a mesmerizing talk, whenever he speaks in any platform. He's so detailed and is very clear in his concept. And really, I was traveling. I made it a point that I should attend his lecture. Thank you so much, Rakesh, once again.
Thank you. Okay.
Amit.
Kavita ma'am. Yes, ma'am.
Yes.
Yes, Uma madam. Welcome,
Amit,
ma'am.
Thank you.
Yes.
I've been here listening to Rakesh as usual. The thing is, we might in future have a medical legal question there. Why the alert card was not given? When you have anesthetized the patient and you had problem, the patient wouldn't know. Why it was not informed could also come as a medical legal problem for us. I think we should be aware of that also.
Ma'am, I think this is right now absolutely voluntary.
Yes.
As long as if you
Yes.
have communicated with the patient, it does not necessary that you have to fill up the form.
Fill up.
It is voluntary, but we wish that if you have already communicated with the patient, then it becomes
Yes,
easy
doctor.
for you to fill up the form
Fill
and
up.
then say that, okay, you can use this QR code in future if you go to any other
Any other.
hospital or any other surgery or a
Yes.
doctor. So this is absolutely voluntary, number one. And the anesthesiologist should decide whether they want to fill up the form and give that information to the patient and then the next anesthesiologist or not. So it's not mandatory, it's voluntary.
In our preoperative patient questionnaire, we have a column which specifically asks, did you have any problem in anesthesia before this? So even Airway definitely comes into that. It is there in the pre-op questionnaire that we are advocating all over the country.
Yes. And see, the only factor in the airway assessment which was identified which has a real sensitivity and specificity is history of previous difficulty.
Yes.
Now, history of previous difficulty, patient does not have any idea about that. This would be a step in that direction where we can actually get an idea that, okay, there was some difficulty and, what was the nature of difficulty. So that is a step in that direction. With this, if more and more people fill up, we can develop an airway registry. So that would be a next step where airway registry can be developed and we can actually develop, sort of on that basis, modified, change or adapt our guideline on the basis of airway registry which we developed. So that's a long way to go. This is actually the first step in that direction where we can have, more information. Dr. Kavita ma'am, your experience in your institute about airway
Dr.
card
Amit,
and how.
yes. Dr.
Yes.
Dr. Amit, just one. As we are talking about this, presently also, even if the airway alert form is not there, any difficulty that we come across, we definitely inform to the patient. As in, because it's an informal way of doing it. We mention it on the paper also, but we explain to the patient as well. So, of course, it is happening. It's not that it is not happening, but it's not being captured as an alert form as a separate document. But it is very much there and we have to explain them as a part of our management. So, whatever it is our duty, because as I told that it's a shared decision, always we do it and it's a partnership. So they have right to know it presently also.
Yeah.
So we definitely do
Exactly.
it. Yeah.
Exactly. I know. See, we would try to do it. We will probably give a discharge summary where we might mention that there was a difficulty, but we are not able to give them proper information, or patient is able to retain that particular paper. So when you ask, they would not have information. Here, there is a structured way where they just need to share a QR code with the next doctor and doctor can scan and find out what was the
what all was difficult can be known in detail rather than just a problem with anesthesia.
It all depends upon the literacy of the person concerned. So naturally, people are informed, obviously, but at times they don't remember what has been done over the years, say last 10, 15 years back. Secondly, what was the literal level of that person concerned whom you've explained it. So now this system, what you have developed, probably will retrieve everything which he has faced, and it becomes easy for the subsequent doctor to face such situations. So this is what is very important.
I agree.
Okay, we move on.
Thank you.
Dr. Kavita, your thoughts?
Good evening. Yes, sir. Actually, we are keeping this difficult airway card, but in today's lecture, Dr. Rakehs has explained very well how to organize all the things, including medication, including difficult airway intubation, mask ventilation, supraglottic. So it's, as he mentioned, we are keeping in the cupboard. So everything should be organized way. Suppose we want to go for the supraglottic, so we can use that. And usually what we are doing in our institute, we keep everything together. So that is the excellent point he has mentioned. And he has also mentioned about code D. That is also very important thing, because usually we mention about the code blue team and all this, but code D is an excellent idea for the future anesthesiology. And another important thing he mentioned about the remote kit. So remote kit is different from our routine. So that is also an excellent idea, and all the things which he has mentioned, though we are doing, but he has mentioned in a systemic and organized way we can do. So that will definitely help to improve the further practices.
Thank you, Dr. Kavita. Dr. Zulfikar, your thoughts in your part of, Kashmir and the northern India. How do you manage your airway cart, and do you have any system where you inform your, patient's relative about the airway difficulty which they might have faced? Dr. Zulfi.
Dr. Rakesh has made it very lucid and very clear. We also do it, but in not so an organized way. In fact, he has shown a clearer path for all of us. Right now, we do informally inform the patient's attendants at the during intubation, after intubation, or after once we are settled with the securing the airway maneuver, that there has been a difficulty and these are the problems. And it's a hospital protocol that we write it on the discharge certificate. That is the hospital protocol. But the way we have made it from Aidaa, things are more clear. And I think it's my suggestion that we should incorporate this set of skills as in our teaching program also. In fact, with multiple simulations and all that, our postgraduates, they should be more acquainted. And Aidaa can take a deeper dive, I think, in keeping in view of the conditions all over India where we have heterogeneity of the resources. We can modify it as per the low resource settings also, so that where in a low resource setting where we do not have all the gadgets available, we have alternatives that do create an environment of safety with proper communication. So once we approach such situations, there's a considerable reduction in the morbidity.
Thank you, Dr. Zulfi. So that takes me to Dr. Parimala, who has asked that code D, whether it is confined only to a particular institution or it can be cater the assistance out of institutes, especially private hospital setup.
It's a uniform.
Dr. Rakehs.
Code D, we have given a uniform way of calling for help, a focused way of help. So like you do code blue, it can be at any place outside the institute also. So when you say call for help, it can be any person at any place, even a small nursing home. The call comes in a different way. So your purpose is to activate the system, and your institute will also have some inbuilt system that if you're facing a difficult airway, who is coming as a rescue. Just to activate that rescue, we have symbolizes in a very specific way. We say activate code blue. Now we say activate code D. So everybody understands that the help is required for a airway management. As simple as that. So you don't have to say, please call that person who is expert in airway. Please bring a difficult airway card. Please bring something which is having, please call the surgeon. Please call the surgical airway. Please get me this kit. So rather than speaking so many sentences, just say, please activate code D. And the message is clear. This is with the purpose is irrespective of the place.
Okay, Dr. Rakehs, more thoughts on list of equipment. There was a discussion. Dr. Pankaj suggested tooth guard, and Dr. Satyajit has into that discussion that entire list of equipment may be difficult. So there is a workable. What Dr. Pankaj told is probably the workable and train, retrain, and develop confidence. Building the team which understands the philosophy is critical in positive outcome. So list of equipment, what is required at your particular institute and what is available. Your thoughts on, the list of equipment which we have identified, and how we can modify it at each hospitals or each institute as per their requirement.
So I think if we just tell a little story how it started, the first list that we created was almost again, each compartment has 20 to 25 list of equipments. But it is as simple as that. Sometimes when I open my drawer and it is not neat and tidy, even to get a key, I will take another 5 minutes just to get a key from a small drawer in my office. Same principle will be applicable for compartment. So out of those 25, 30 equipments, the team considered that this is the most essential one. And we have to declutter the equipment. No confusion about it. 3 days back, I just cleared my drawers and I realized that out of 4 drawers, 2 were absolutely empty. And I could arrange so many things beautifully. Same purpose is for this compartment. We have kept minimum equipments. We don't say, for example, if you have 3 different type of hyperangulated beds at your center, no need to put them all, just keep one. No need to put up a tube if you're managing an adult airway OT. No need to keep a size 3 or 3.5 or 4 size of endotracheal tube into this. So this means you have to declare it. This is number 1. If you see the guidelines, we have mentioned it very clear. Number 2, each compartment or a difficult airway card can be modified as per the institutional needs. Suppose, for example, if I'm managing head and neck cancer clinic OT, which is my part, and that is my OT specialty, I will have equipments for that aspect. If somebody is doing cases which are more in supraglottic airway devices, they will be more part of it. But we have compartmentalized it. If you see the compartment 3 and 4, they are very simple things. Just supraglottic airway devices and a catheter for intubation with suction. 4 just will have surgical airway. The compartment number 1 is for oxygenation devices. Compartment number 2 for the airway management. So in this also, you need not to keep everything. For example, if you want to keep a Goodell's airway, there is no need for keeping Burman's airway for a small size airway. Just keep as per your requirement because this is for usable purpose. Just remember, I will just stop at one statement. Difficult airway card is not the storage area for your airway equipments. Storage area is separate, which is inside the operating room. You keep your equipments there. Difficult airway card is a usable, minimal, essential equipments according to the strategy kept there. If something you want more, you can always get it, but minimum should be there. So we fully agree that it should not be cluttered as Dr. Pankaj and other audiences mentioned. Keep to the minimum so that you are usable as per the requirement and it can be modified, adapted as per the institutional needs. Dr. Shweta, please. Yes, ma'am.
Thank you, Rakesh.
Yes, I just wanted to ask regarding the first discussion we did, how about the code deactivation and the team? How do we create that for freelancers or the standalone anesthesiologists who are working in the standalone? I mean, is it the ISA or the local group that should come across and the team of experts should be created, trained? How do we do it? It's a great concept, but how do we implement this?
I think very important. I showed 2 slides for how to operationalize the code. I got 2 slides. The first thing is just create a team. I will ask you a simple question, madam. How have you created code blue for your hospital? Do you think on the whole hospital, whether freelancers or a nursing home or a small center, is a single anesthesiologist maintaining the difficult airway, the cardiac arrest at all places? No, they have a team. Team is with whom? They will have different professionals. Now that's why we have to create a team. And the role allocation, if you remember the team dynamics, the role allocation. Sometimes we have to train our OT technician, we have to train our staff nurses, we have to train our surgeons. If you train them, they are part of our team, right? So if we can make that team depending upon wherever you're working. I understand if somebody is a solo freelancer, he will not get 3 trained anesthesiologists in the same operating room because the finances will be divided between 3 and it's not required. But yes, I am also aware of freelancers when they anticipate difficult airway, 2 persons reaches. Or when I work in my operating room, it's a difficult airway. I always call my colleague in a nearby theater that it's a difficult airway. If I call, please be around and come immediately if I call you. So this is the system that will be institutionalized. Everybody will have a different requirement. Everybody will have different way of training these peoples. But yes, the most important aspect would be once you create a team, I would suggest once you do a simulation and do a mock drill. Just do a mock drill, call people and see how people will bring up. Just do it once or twice, everything will be in the system. So that's the operationalization of the code D and getting the difficult airway card. And that works well.
Actually, just to add to all that, madam, I mean, what I have, the head and neck cancer surgeon at whom I work with, we do a lot of laryngeal surgeries also. So many times he says that I would prefer intubating. So I allow him to do it. So when I really have a difficult intubation, he is the first person to help me. That is one thing. And one more thing, I would like to make a comment. Almost every city has one or two anesthesiologists who have their own fiber optic scopes. This I mean, I have don't have the exact studies, but most cities do have. So most of us, what we do, if we realize that I mean, I don't have to do it because my surgeon, we have a FOB at my place. But many anesthesiologists in private who feel that they're going to have a difficult case, then they inform the person with the FOB to, please come and help me in the intubation the next day. So this is how we do it in private. And of course, I feel every city has groups. So in case, not just for code D, but for any other problem, we always put a comment on the group. Please, I have an emergency. Please come for help. So this is how, at least in Nasik, we follow it. If anyone puts it on the group, whoever is free tries to rush to the help of that particular anesthesiologist.
Yes,
So,
yes,
I
I
mean, these are
agree
all.
completely because nowadays
Group practice.
encountering unanticipated difficult airway has become less because of our PACs and our
Yes.
sensitization for the same. So once we know, as Dr. Rakesh said, that we anticipate even a slightest of difficulty, if it crosses our mind, then we definitely inform the senior or a colleague and keep the equipment. Our preparedness is there already. And so if any other person has to pitch in, then situational awareness is already there. The mind is already started preparing. So most of the time, because there is already an anticipation, we should be involving the other person right from the beginning rather than the last minute. That is what the message is. Many times we know there could be little difficulty, but we don't inform. We don't escalate to that extent. And that's where we'll end up in problems. So here, I think wherever there's a slightest difficulty, as we said, early help is rather, it is the prophylactic help. So the second person should be informed so that the person is available, the equipment is available, and we do not lose the precious time during the crisis. Thank you.
Thank you, ma'am. Dr. Kavita raised
Yes,
her hand.
yes.
Dr.
Yes,
Kavita.
that thing I was telling that Dr. Rakesh has already mentioned that initially when you first time face the problem, you immediately activate the code D. And most of the time freelancers are nowadays doing group practice. So you can immediately call them. And one concept is there, anesthesia technique. And in some places, anesthesia technicians are also there. They are also well trained and they can also help if we tell them. So these are the different ways. But on the first call, we should activate the code D. First difficulty, we should activate the code D. That is the most important thing that we can do.
Yeah. Thank you. I think we can continue discussion while I will take you through the Rakesh, is there anything remaining in the chat box?
No, sir. I think we have covered almost everything. So I've just checked it.
Oh, okay. Yeah. Perfect.
And thank you each one of the participants for wonderful questions and wonderful insights. So thank you each one of you who are giving such a wonderful queries and replies in the chat also. Thank you, everyone.
Thank you, Dr. Rakesh and Dr. Amit, for that our participation. We are very happy for this.
Yeah. Thank you,
Thank
ma'am.
you so
And
much.
all of you should fill up the Google form for the attendance certificate. Okay, so now I'm taking you through the Aidaa website. Okay, so this alert form can be accessed through the All India Difficult Airway website. So when you go to Aidaa website, that is actually a pop-up. And when you go down, here is a Aidaa Airway alert form. So when you click on that, it will take you to the Aidaa Airway alert form. So these are the information you need to fill up. Mobile number, hospital number, date of event, what was the surgery, was this anticipated, yes or no? So that means you can identify whether it was an unanticipated airway or anticipated difficult airway. You can enter the risk factors which were there, which you anticipated. What was your primary airway management plan? And then what were the difficulty? So some of tick box which we have identified that, okay, we had a extubation or intubation difficulty or a supraglottic airway or a video laryngoscopy. And then if you want to specify anything further, you can always add in that comment part. So here you can do a tick here, and then you can always add if you want to add any information. Then how have you planned the further management? Suppose you planned supraglottic airway failed, you have done a video laryngoscopy or direct laryngoscopy, you do it awake, you woke up the patient, you did supraglottic airway insertion or a fiber optic or a cricothat, or if you want to identify any particular information among these options or any other options, you can put it in the comment. Again, if there were any complications, we have identified few complications which are there. You can add more detail on that complications, or any other complications can be mentioned here. And then what was the patient outcome, whether patient was transferred to ICU, surgical airway, mortality, or obviously mortality may not required here because then we don't need to put alert form, but right now that has been added, but we may remove that. And extubated wake up in the operation room. And here the anesthesiologist's name and designation, but that is voluntary. Okay, if you do not wish to put your name or designation in that alert form, you can remove that. You can also put your suggestion that, okay, in future, what I would have done different or what can be done to improve the airway management. Now that has been added. Again, it is anesthesiologist's prerogative that whether he wants to give this suggestion or not. So you can enter information here. If you want to wish, then only you can display, other it may not be displayed to the alert form. So there are a lot of options where how you want to share your information. Okay. And then in the last, whether you want to allow this data to be used for patient registry. So we want to develop a registry of complications. So if you wish to be part of that, we can, you need to give consent for that. If you give consent, it will be part of registry. Otherwise, it won't be used for patient registry. When you put up the information, whatever information you have added here, okay, will be summarized. So there won't be entire form again when they open the, when they receive the QR code and when they open the alert form. Suppose if I put difficult mask ventilation, and I have said that we had actually put the supraglottic airway insertion and our patient was, then we woke up the patient. So all these 3 or 4 important points, whatever was there, would be described in that alert form. They won't have this entire form again, but it will be summarized to the next anesthesiologist. So when you submit, you will receive, since you have already added your email ID, you will receive a QR code on your email. And when you scan that QR code, you will receive the information which has been filled up by the anesthesiologist. Of course, the this QR code will be shared with the patient if anesthesiologist wants to do it. And then when that patients or their relative, whenever they scan that QR code, they'll get this information. So this is how our alert form is going to work. We are again open to the suggestions. If anyone wishes to have any further, if they want, if they have any critical remark, we are open to that. You can always email on our official email ID aidaa2010@gmail.com, which is there on our website. So please go through this alert form. If you have any patient or any information, please fill up this form. We would be really happy to help you to share this information with your patient and the next doctor. Dr. Rakehs and Dr. Said Mohit sir on this form.
So, Doctor, I think we can have a feedback. So if you think something is lacking, we can always add on or delete something. Some of the things are optional, so you can select not to fill them up. And we will try to make it little anonymous so that even for the registry purpose, when we initiate as a part of registry, it will not be coming from which source it is coming up. But right now it's optional, but it will be a ready-made tool, and you can give it to the patient, or simply you can keep in the hospital record also, so that it remains a part of your discharge summary or a PAC sheet, so that it becomes easy for you to use it next time. So it will be a ready-made nice version of the alert form, which you can always refer to for subsequent things.
Thank you. So this is live now. You can, whenever you wish to fill up this form, you can always fill up this form. It is there on our website. You click on that and put up the information, you will receive an email.
Can I give a suggestion here, Dr. Amit?
Yes, sir.
Yeah. One thing I'll suggest you, if you can put up the patient's photo also, maybe the side profile with hiding his identity. And that is one thing which can be added into this. And secondly, Aadhaar card ideally should be, because you may always have two patients with the same name, because it's going to be an all India basis. So in some way, if you can confirm the identity of the patient so that there is no repetition if the names are same. These two things I'll suggest, if you can add to the form, it will be really useful. The photo obviously will make a lot of sense. We get to have an idea of the anatomical landmarks, and secondly, the identity of the patient. Just a suggestion.
No problem, sir. As such, right now, the concept is such that it will be filled up by the anesthesiologist and will be given to the kin of the patient or patient himself. No one else will have this particular information unless patient decides to share it with their friends or anyone else. So it will be either that particular doctor or that particular patient is only going to share this information. So, but anyway, we can.
சென்னையில நிறைய வெயிலா?
So we can discuss that, and yes, we can add that if patient gives consent for that. So once we put up this sort of information, we would like to take consent of the patient, whether he wishes to put his photographs there or not. So that we will discuss, and yes, in future we can always add that. Any other suggestions?
No, I would say, Rakesh, I would say one thing, that these forms should be as simple as possible and as as specific as possible. So naturally, putting more, adding more information, more in the form of which might not be very compatible with patient's idea. Like, for instance, putting a photograph, giving an Aadhaar ID. I think people might not be very comfortable in doing that. So I think as of now, what our primary intention is to let the patient know that he had an problem and let the anesthetist know as well, whoever will be dealing in subsequent operation, that let him know what all problems he had. So this is the basic idea now, but in future, obviously what Pankaj is saying, probably it will not be that simple to do it, but we can keep it as a point.
Yeah.
Okay. Can I suggest something? Yeah.
Yes, Dr.
So just a thing about when we are writing a note to patient, we have said that for safety during any future surgeries. So I say we may write anesthesia rather than surgery, because many times anesthesia is given for ECT and for not for surgery. So if we write that this is for anesthesia and not for any future surgeries, it'll be more meant for the anesthesiologist, and the patient also understand the importance of this, even if that means it will sensitize the patient enough for anesthesia and knowledge about the anesthesiologist, the role of the anesthesiologist.
I think it makes sense. It makes sense.
Yeah.
It is more specific, and moreover, certain at times patient might be undergoing surgery where you don't need to give any anesthesia. So in that case also, so probably it is more specific to make it anesthesia. I think
rather than saying surgery, it's a verbo we use it, but here if you mention it, it's better. That's what I thought.
Exposure to anesthesia. I think that can be incorporated. Makes sense.
Perfect. So I think with this, I will shift to the last section of our segment, that interesting segment of Kahoot quiz, and I will take you through that. Okay, so I'm starting the Kahoot quiz. That's the last part of it. And we are loading the game pin. So what you need to do is to go to the website Kahoot it or Kahoot app. The moment you go there, it will ask for you for a pin. If you have a mobile, you can scan this QR code. That will also take you to the Kahoot it. Please enter this game pin. If you have any difficulty, you can straight away unmute yourself and ask or put it in the chat box. They're very simple questions made by our quiz masters.
Amit, you're muted, I think. Cannot hear you.
Yeah. So please put up your proper name. That would be easy for us to identify who was the winner for this particular quiz, number one. And please fill up the form. Then only we will be able to send you certificate as well as discount coupon for National Airway Conference. Those who attend this will have chance to get a discount for the registration of Airway Conference. I think, Rakesh, shall we start or we'll wait for one more minute? More people are joining, but it seems to be stabilized.
Maybe another just 30 seconds.
Okay.
So
even if once this starts, the game pin will be displayed at the bottom. You can join anytime. If you, by some mistake, if you log out, you can again rejoin. Just remember this game pin and it will be displayed at the bottom. I think it seems to have stabilized.
sure, sir.
Okay. So let us go ahead and start. The game pin is still there. It will be displayed. Don't worry. So this is code D, cart and alert. Once again, reminding you about National Airway Conference and International Airway Management Meeting 2026. This is a dedicated National Airway Conference. There is a, this Quizinar series is going on. There is a hands-on workshop, focus learning session, paper, posters, and a lot of awards to win. So all of you are welcome at All India Difficult Airway Institute, New Delhi. The dates are 9, 10th, and 11th October. You can visit our website and register. Once again, thanking our quiz masters, those who have helped us in preparing those questions, Dr. Kiran Mahendru, Dr. Indubala, Dr. Shilpa, and Dr. Shripad. Thank you so much to be part of us, the part of this and helping us in developing very interesting questions. And once again, thanking our chairperson. You must concentrate on questions and options. There are a lot of images are there most of the time to make it interesting, but they may not represent exact question or answer. So please look at the text carefully, and you need to be correct and fast. You need to be correct, and whoever gives answer earlier will get more points. So let's go. The first question coming up. Primary purpose of difficult airway cart. You have 15 seconds. More and more people are answering. Most of them have given correct answer. That's streamline. 27 of them has given us correct answer. So please do not put this correct sign on the screen. Okay. Someone has, done it. So please remove that if you are able to do it. There is a pan option on your screen on your Zoom, which you can do it to remove it. Okay. Next. What is a carry kit primarily intended for? So this green yes correct sign is done by someone. It's not done on this from the Kahoot quiz. It could be misleading. I think most of them should give a correct answer, and that is outside operation room, and most of them has again given a correct answer. It is not for cardiac surgery. Dr. Rakehs, if you want to give comment or thought anytime, please fill in. Okay, so NP is right now leading after 2 questions with 1800 point. SEED is just behind with that 1864 point, and Singapore is at 1833. So it's a very narrow margin and very what do you call interesting race. So what agent in our airway cart is recommended for oxygenation? And our options are tracheostomy tube, nebulizer mask, jet ventilation, and nasal oxygen device. This green corrects.
Somebody is putting the correct green color marks. May I request if you can just
to remove it.
People will get confused by this.
So that is why people are, if that is the reason, then people are given jet ventilation. Ignore this green correct part, okay? That is done by someone, may not be, purposefully, but it is there, and ignore that part. We are not in right now, not able to do it. Someone else has also done it. Please, on your screen, there will be a green, arrow is there, which you can remove. Okay, with that you can remove. Okay. So the correct answer is nasal oxygen device. It is part of the adjunct recommended for the oxygenation. Ignore this correct sign, okay? And let us then look at the... So now Sid has come up. He has given answer correct and fast. So the board has completely changed. The 2 leaders which were there earlier are not in first 5. And SK is the highest climber, up by 9 place. What does difficult airway cart modularity refer to? DAC is difficult airway cart. Again, please ignore the green correct sign. Okay, everyone has almost given answer, and most of them has done correct. Rakehs sir, if you want to comment on this.
So there are certain features about the difficult airway cart. So when we say the modularity means we have strategies. So if the first compartment we were talking about the oxygenation devices, second tracheal intubation, third supraglottic, and fourth surgical airway. So when we say this modular format, we know that we are working on this modular. So we do not have a stepwise approach, it's circular approach. That's why if somebody is, say, missing into this, they wants to move to the, we can say, the second airway strategy for managing it, they can move very nicely. So this is called modularity. And yes, decluttering is important, which we have discussed. So fewer devices, it doesn't mean fewer devices, this means essential devices. So essential devices for that compartment, for that strategy should be there. So this is what we refer as modularity.
Thank you. Let us see the leaderboard. So Sid is still leading with 3688, followed by Singpa and Spurthi. Okay, and PP has a strict with 4 correct answer in there. We'll go to the next question. Before that, let me erase that. I will realize that I can do that. Okay, done. So let me go to the next. Okay. Which record is not recommended by Aidaa? I think this should be easy. Everyone has given in very short time. That's financial audit. Rakehs sir.
So yes, again, this is important because when we make a difficult airway card, we need to check it thoroughly. So daily checklist was important because if you have used something, it should be replaced. Inventory log, because we have said it's modularity, essential equipments are there. So you need to check the inventory log that if something is missing, needs to be replaced. If somebody has used it, it's a usage log. Financial audit register, we are not keeping it for this purpose for Aidaa. It will be for the hospital uses or for accounting, but these are not part of the airway management guidelines. So we are not concerned here with the financial aspect for airway management or for maintaining the difficult airway. But yes, those who are working in a private setup where each patient is charged for whatever is being used, so that may be separately kept, but not as a part of the maintenance and operationalization of difficult airway card.
Okay. So Seed is still leading. So leaderboard is more or less same right now. There is slight difference. Okay, we'll go to the next. Who should receive airway alert card? Think things should be relatively easy. You already identify who should be receiving this. Yes, patients or surrogate. This is for the alert. This would be received by the patient or surrogate, their relatives. It will be in future, if at all, if he undergoes some surgery or if he undergoes some anesthesia, as Dr. Sweta suggested, then the next anesthesiologist should receive this, but it will be given to the patient's relative. Okay, still Seed is leading. So more or less leaderboard is remaining there only. Others, please come up. You need to answer correct and faster. What issue prompted the code D? I think I could have kept even a 10 second for this. Most of them answered in 10 seconds. And yes, everyone absolutely clear. It is ambiguity in the calling about difficult airway.
So this means there is no ambiguity in the answer also, sir. So this means
yeah,
code is specific.
Yeah, very okay. Now this is a situation specific. Read carefully. Though answer by elimination is absolutely clear. Again, very clearly, Rakehsh sir.
So this is a very important aspect for when we say anticipated difficult airway. So when we say the high-risk population, pregnancy with eclampsia, we understand that it will have airway edema, it will have because of the hormonal changes with large breast and also and so forth. So pre-eclampsia as well as pregnant patient, and then it's an emergency LSS with full stomach. So these are all the high risks that we need to emphasize, and that's why we have to activate a difficult airway in this scenario because patient may have concerns during the airway management, and most importantly, we are managing 2 lives. So any amount of desaturation is catastrophic. The pregnant patients have lesser reserves, lesser FRCs, again adding up to the decrease of apnea time. So this is all we have to anticipate risk, prepare our patients, prepare our gadgets, and keep the airway card, difficult airway card, and call for help ready when we are managing these type of situations so that we can avoid any type of morbidity in these patients.
Now there's a slight change in leaderboard. Slight change, still maintaining. Their last 3 questions are remaining. Oxygenation device fit the compartment 1. So there are a lot of devices, 4 devices we identified. Which one is in compartment 1? So for that, you need to listen. You should have listened to that. So again, most of them is. Yes, Rakehsh, please.
So if we see the compartment number 1, which is primarily the oxygenation devices. So the Aidaa says that you have to oxygenate all patients, and oxygenation should continue during the airway management. This compartment contains bag and mask devices with reservoir with oxygen tubing. Number 1. Number 2, you have oxygen source. At least it can give you 15 liters. And when you have a reservoir, you can give 100% FIU. This is important. But nowadays, many centers have HFNCs available. So in case if they are considering those patients, especially in those where you anticipate difficult air. The cricothyrotomy cannula, the jet cannula, they are part of the surgical airway or emergency cricothyrotomy compartment, which is, we are not saying exactly number 4. You can keep it as per depending upon the type of the cart you have. Entry catheter is when you want to intubate through supraglottic airway devices, which is a part of the compartment where you have put SGA, but you need a definitive airway, a cuff tube. So you can use entry catheters in those situations as an airway adjunct for replacing or introducing the endotracheal tube via supraglottic airway device.
Okay, thank you, Rakehsh. And let's see. Leaderboard is slightly changing. And let's see the next. Intubation through supraglottic airway. Don't look at the pictures, only look at the options in the text. Rakehsh.
So when we talk about the intubation via SDA, I just mentioned. So in some of the cases, you plan to have a tracheal intubation, but you realize it's a difficult airway. So it's a circular algorithm. So you shift to SGA. But there will be certain surgeries like bowel surgeries where you anticipate that there will be a lot of airway pressure changes and the chances of high risk of regurgitation, long-standing surgeries, or patient requires surgery in lateral or prone position. So supraglottic airway device may not be the ideal equipment for continuation of the surgery. So now you have taken a decision that this SGA, though you are able to ventilate, your airway is secured, but you need a device for the surgery to happen. In those situations, the second generation devices, we can put up a tube through the SGA. There are various methods. Nowadays, usually we say it should be a visualized technique rather than a blind technique. You can use video endoscope guided intubation through the supraglottic devices and secure endotracheal tube. The other option is airway exchange catheters or entry catheters. Along with the use of flexible scopes, you can use them to intubate through the SGA and get the surgery done. So this is what we do. Rigid bronchoscopes are also used for difficult airway management when the structures are there in the oral cavity or the antilarynx. Rigid bronchoscope can be used for those purposes. So they cannot be used for intubation through the SGA. You need something which is softer. Frova introducer and Eastman stillet are different type of introducer and stillets which are being used in difficult airway and anterior larynx. So in those situations, you can use it. But entry catheter remains one of the acceptable norms of guided intubation through supraglottic airway device.
Okay, let's see the leaderboard. Now it is changing. PPS come up. Okay. This is about which item belongs in the outside OR carry kit out of this.
Okay, so some of you have put a surgical tracheostomy set as a part of difficult airway kit to be carried outside. So the portable video laryngoscope is definitely the right answer, because outside the operating room, we have substandard environment in the sense that it may not be appropriate position, patient may not be at appropriate height, you may not get good view. So use of video laryngoscope is definitely an acceptable option outside the hospital, more outside the operating room. This is more beneficial. Sometimes people have used video laryngoscopes from the sides because they can see a view. Channel scopes has been used from side in a crunchy area, in a situation where the access to the patient is not well, like in a radiological suite. So the correct answer is part of the kit includes portable. Rest of the things are part of the difficult airway cart, especially the jet ventilation and the fiber optic bronchoscope. Now commonly called as fiber optic, not fiber optic, but flexible video endoscope. So this is the correct terminology. The surgical tracheostomy set is not an emergency surgical airway. If you are stuck up as a complete ventilation failure, and routinely the Aidaa suggests that surgical cryothyrotomy should be the preferred choice, and the use of scalpel bougie tube technique remains the preferred choice. Surgical tracheostomy set is usually for anticipated routine elective tracheostomy can be done for those patients where the surgical help is required. Surgical help is there. In those situations, you can use. But if you are stuck up and the patient is, you are in a situation of a complete ventilation failure, so the option would be surgical emergency cryothyrotomy. In case if you want to use needle cryothyrotomy, in that situation, you cannot ventilate through the needle of 14 or 16 gauge. If you have used needle, always you should have availability of the jet ventilations so that you can ventilate using jet. But remember, when you use it, there should not be a complete upper airway obstruction because you need some space for egress of the air. So this is how the contents and their justification where to use it, because outside the hospital, outside the operating room, you may not have a source of oxygen to connect the jet. This is a heavy equipment, so not required for a carry kit as such.
Thank you. Let's see the leaderboard. Things are changing. So this has come up, PP, MK, and Singh. So they are just behind. Okay. Difficult record not recommended. Okay. Which is actually a reality.
So I think almost everybody is correct. So if you remember, before the concept of difficult airway cart came up, every OT usually have a cupboard, an almirah where all the equipments are kept, and some of them are costly, so they are locked or they are at distant places. So somebody has to run and get those equipments, and those almirahs are not movable. So that's the reason a lot of time and the manpower where you need actually the helping hand was just used for getting the equipments one by one. And that's why this restricted access was converted into a mobile, modular, uniformly, easily accessible, standardized, difficult airway card. So these are various characteristics of DAC. And this is what we need to follow to arrange DAC as according to our requirement.
Okay, thank you. And let's see the leaderboard. The PPS come up, and let's go to the last question. What is compartment 3 primarily indicated? Third compartment. We have seen first, let's see, Rakesh has very clearly said this at many stages. Rakesh.
So again, I think some of them have put cricothyrotomy kit as a part of compartment 3. So compartment 1 is oxygenation, compartment 2 is tracheal intubation, compartment 3 is supraglottic airway device, preferably second generation, and compartment 4 is surgical access. So we have tried to compartmentalize so that everybody knows that open up the compartment 1. So this will maintain a uniformity, and that's why we have not labeled as drawers or up, down, because every place will have different type of carts available. So that's why we have labeled them as compartment, not drawers. Somebody may have open boxes also. So that's why they can say, give me a compartment 1 equipment, open compartment 1. So it will save time. That's why it has to be little standardized. And second generation devices remains a part of compartment 3. Cricothyrotomy kit remains a part of compartment 4. Nasal oxygen cannulation remains a part of compartment 1. Direct laryngoscope remains a part of compartment.
Okay, that takes us to today's podium. Number 3. Spurti is at number 3, PP number 2, and at 11,411 is Shudis. Thank you all. Let me stop share for Rakehs sir. Floor is yours.
Thank you so much for joining us for this interesting session. I'm sure that we'll make the airway management more safer with us, more safer for us. And a very special thanks to all the chairperson who has spared their valuable time. They come up with their expertise. They have shared their very valuable experience, and also not only experience, but I would say the important tips and tricks that they have shared. So special thanks to Dr. Pankaj Gupta for sharing his experiences and sparing time and be with us throughout the time. Special thanks to Dr. Zulfikar Ali, again for coming up, Dr. Sudesh Khanan, Dr. Shweta Salgankar, and Dr. Kavita Lalchandani madam for sparing time and helping us getting more insight, more experience, because airway management is just not the strategy, it's just not the guidelines, but also the learning skill and experience do matters. And that's why we say, use the tool which you know the best. But we usually add on the line that you should know most of the tools, how to use them at the correct time in the correct way. We also thanks to our quiz masters, which has been helping throughout for various kahoot quiz, interesting questions, Dr. Kiran Mahendru, Dr. Indu Bala Moria, Dr. Shilpa Bhatt, and Dr. Shripad Mahendale, who has been creating this platform of kahoot quiz with Dr. Amisha taking a lead again for this kahoot quiz, making it interesting and getting the scoreboard us. And each winner will get a not only a participation certificate, but the first 3 winners will get a special certificate. Please fill the form through the Google link that we have shared. We'll be sending it through a soft copy through email for today's winners of the quiz, and the participation certificate for the Quizinar will also be given to everybody. Special thanks to Dr. Syed Mohid Ahmed, the president Aidaa. In spite of his busy schedule, he came up. And thank you, the whole Aidaa team, Dr. Mohid, Dr. Amisha, Dr. Suma madam, everybody who joins from the Aidaa team today. And special thanks to Dr. Amit Shah once again for taking an extra effort to finalize the registry, finalize the online airway alert form and release it. I'm sure this alert form will be helping to many of you. You can just try to fill it up. If you feel like, you can give it to patient. If you don't feel like, you can keep it with you for your own audit. But I would request, even if you are not giving to patient, just fill the form and keep the filled form with you. And after 100 cases and 200 cases realize, I'm sure that you will be really amazed that you have managed so much difficult cases successfully, and you can audit yourself. And again, it becomes a good paper for publication. Aidaa is having its own journal, the Airway journal, wherein you can get this audit done, and we will be happy to publish this type of audit from the registry into the Airway journal, which is now DOJ indexed also. So use that platform for publishing your registry data. You can use it, and you can always collect data and use it for publication into the Airway journal. So thank you once again, and we'll request Dr. Amit Shah for a closing remark.
So thank you once again, everyone. Dr. Rakehs, my Aidaa team members, my esteemed chairpersons for sparing time and joining us in this very interesting session, and a landmark for us, because now this was our idea of doing Airway alert card since a very long time, and we could make it finally. So thank you for joining us. Good night, and do join us after 15 days. Again, we will be coming out with another Quizinar. Thank you so much. Bye-bye. Good night.
Thank you very much, sir.
Thank you all.
Good night.
Thank
Great time.
you for
Thank
inviting us in this webinar.
Thank you, sir.
Thank you.
It was very
Thank you.
interactive and
Good
very
night.
informative, actually.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Yeah,
And good.
great
Dr. Sudesh,
discussion.
congratulations. PP was me behind you.
Yeah, I was
Practitioner.
just participating just for fun, sir.
And exactly.
So very
Yeah,
great
thank
work
you.
done by Aidaa, but yeah,
Yeah,
Yeah.
thank you.
fantastic. Very good.
Thank you.
Yeah, thank you, sir.
Thank you, everybody.
Thank you.
Good night.
Thank you.
Everyone,
Good night,
thank
sir.
you.
Good night.